So I'm going to start to look into some of the studies and research that's been done, particularly how it positioned amyloid in this field. So very basic, as you all know, atrial fibrillation is the most common cardiac arrhythmia. It's affecting about 2% of the population. There's a strong relationship with the age of the patient. So if you're in the 50s, it's about 1.5%, but patients who are 80 years or older, it's about 1 out of 4 patients who have atrial fibrillation. A bit more common among male than female, 20% more common. So today it's estimated that in the US it's somewhere between 3 and 6 million people who are affected by atrial fibrillation. And as people are living longer, aging population, and as the post-Second World War baby boom are now reaching this age, it's expected that there are going to be much more patients in the future and need treatment for cardiovascular disease. So for AFib, it's estimated that more than 8 million people will have that in the US by the time of 2050. So one of the most feared complications for atrial fibrillation is stroke. And we know that it's accounting for about 1 out of 5 stroke in the US is caused by atrial fibrillation. And you can also say that patients who have atrial fibrillation have a 5-time increase for stroke compared to patients without atrial fibrillation. The whole story about left atrial appendage is that it's been shown that about 90% of these clots are formed in the left atrial appendage, which makes sense, therefore, to try to exclude that from the circulation. And also proven that strokes which actually come from a clot in the left atrial appendage are causing more severe strokes. It's more disabling and have a high rate of mortality. So how to prevent stroke in these patients? We know that oral anticoagulation has been used for many years. Vitamin K was in the beginning, and now I think everyone has changed to NOAC or DOAC to do it. It has at least the same efficacy and a better safety profile than vitamin K antagonist. And then there's a question, should you have a mechanical treatment like surgical ligation or plugging of the left atrial appendage, or should you do it percutaneously? So surgical treatment is today, even though it has been suggested to do it as a standalone procedure, mostly done as a concomitant procedure to other surgical interventions. Whereas percutaneously treatment, endocardial treatment is today mostly done as a standalone procedure. If you look into the guidelines, the recommendation is quite weak. It's a 2B, so it's something which may be considered, not something that should be considered. And you can also argue that's due to the lack of evidence. Most patients who've been treated is patients who have absolute contraindication for oral anticoagulation, but we don't have any randomized trial. Boston tried to conduct the ASAP-2 trial, but have to terminate it. It couldn't enroll patients. It was too late in the clinical history. And we also have randomized trials on patients who have a high risk, PROTECT AF and PREVAIL. But again, despite a positive outcome and also a better safety profile, at least with the PREVAIL, it's against vitamin K antagonist, which is not used anymore. So that's why we need to have a stronger evidence burden to try to change this recommendation in the guideline. Catalyst and Champion AF is hopefully going to help with that. So what do we know from about device selection in these patients? For the Amplatzer, the first device coming out, Amplatzer cardiac plug, was approved in Europe in 2008. Modified to what we know today, called the Amulet in 2013, approved in Canada in 2017, and in the US in 2021. You can see there's been a number of registries, particularly from Europe, also some randomized trials. I'm only going to focus on 2 of them. The Amulet IDE conducted to get approval in the US, comparing Amulet and Watchman. And then the switch study, the switch Apero, which was comparing again Amulet and Watchman. So starting with the Amulet IDE study, we now have 3 years follow-up. It was almost 2,000 patients randomized 1-to-1 between Amulet and the Watchman 2.5 device. So the post-procedural antithrombotic therapy for amyloid was dual antiplatelet therapy or oral anticoagulation for 45 days, followed by DAPT and up to 6 months, and then single antiplatelet therapy. More aggressive in the Watchman group, where patient had to be on warfarin for the first 45 days according to the IFU, followed by DAPT up to 6 months, and then once again single antiplatelet therapy. And we now got, as I said, 3 years follow-up for this study here. And what we have learned is that if you treat the patients with an amyloid compared to a Watchman 2.5, you're going to have a more effective treatment. Less rate of moderate or severe peer-device leak. You can see it's about 63% lower rate if you treat the patient with an amyloid. And also, if you make an analysis, what is the risk of a peer-device leak at 45 days, what is coming out as an independent predictor is to treat the patient with a Watchman device. So, one of the reasons that you have a more effective treatment with amyloid is the dual design here. You both have a lobe, which is sitting in the proximal part of the left atrial appendage to try to seal off, and on top of that you have the disc sitting at the orifice, so you have a 2 steps sealing off, which is giving this more effective closure. And also, it's more forgiving device. It can be used in more anatomy. So if you look again in this trial here, you can see about 3 times as many patients could not be treated with the Watchman device compared to the amyloid. So the amyloid offers a treatment of a wide variety of anatomy, both the traditional chicken wing, windsock, in reverse chicken wing, curly flower, or a cactus anatomy. So now I said we have the 3 years follow-up, so you can see that patients treated with the amyloid had a higher chance to get off oral anticoagulation at 3 years. So at 3 years, it was about 3.7% of the patients who were still on oral anticoagulation in the amyloid group compared to 7.3% in the Watchman group. So about 50% reduction in oral anticoagulation for the amyloid. And also very interesting, if you look at mortality at 3 years, there's a trend to lower rate of mortality, both for cardiovascular mortality and all-cause mortality, in the patient group treated with amyloid compared to the patient group treated with the Watchman. So about 20% reduction in mortality for the amyloid group. Then you can argue that the amyloid IDE was using the Watchman 2.5, and everyone knows that today Boston now have Watchman Flex. So if you look at this smaller switch apero study here, again randomizing patients between amyloid and Watchman, and you can see the majority of the patients here actually was treated with the Watchman Flex here, 85%. And if you only look at the cohort which were treated with the Watchman Flex and compared that to the amyloid group, that once again you saw a higher efficacy. So the risk of having significant peer-device leak was 50% lower for the patient treated with the amyloid compared to the patient treated with the Watchman Flex. So just to summarize this, so for amyloid, there is a superior efficacy with a closure rate compared to the Watchman, both Watchman 2.5 in the IDE study and also Watchman Flex in the switch study. Freedom for oral anticoagulation at 3 years was much higher in the amyloid group. It's about 50% reduction for the amyloid compared to what you see with the Watchman. And also more patients can be treated with the amyloid compared to the Watchman. It's about 3 times more patients who cannot be treated with the Watchman compared to the amyloid, according to the IDE study here. 30% in the Watchman group was not suitable for the Watchman compared to only 9 patients in the amyloid group. And again, very interesting, in the IDE study, there was a trend to better survival rate for the amyloid patients compared to the Watchman. I think I will stop here and we can go to the next speaker. We're going to have a discussion at the end of these. So, Chris, if you can continue here.
All right, so now we're going to talk a little bit about, like, specifically how is Watchman and Amulet different in terms of the device design and the actual implantation procedure. We're going to go through a little bit about device characteristics, measurements, briefly. Sizing is definitely a difference. Positioning is a difference as well. Markers of when you have a good implant, different. Testing the device stability, a little bit different. Release criteria are different. And the post-implant drug regimen is different. To give you a concept about how these devices are different acutely in terms of occlusion, the Amulet is a much more dense device. There's less free space within it. And there are multiple layers separating the left atrial blood pool from the distal appendage. So this was a little demo that I did in my kitchen for AFib Symposium, just to demonstrate generally, like immediately after implant, comparable appendages, both the size of a Coke bottle, and the device is like 30% compressed in each situation, but a lot of the fluid gets hung up within the layers of the Amulet immediately upon implant. So the key is that Watchman is critically dependent on total occlusion by endothelialization of a single layer of fabric. Like otherwise, it's not going to be completely occlusive. Whereas Amulet, even if the device is not endothelialized on the surface, there's a good chance that the appendage has no flow and is completely occluded. There's 5 different Watchman sizes. Now, if you actually look at this, the more you compress a Watchman, the longer it gets. So actually, if you're not limited at all by depth, potentially you could cover almost every sized appendage with either a 35 flex or a 24 flex. You could pretty much cover the entire spectrum. So, it's like 2 devices. There's like a big device, a small device, but there's lots of little ones in between. But there's a ton of overlap. So you don't have as much like millimeter by millimeter change in what's going to push you between one device size or the next. And sort of to amplify that, this is as you extend or stretch the device between the different compressions, like how much longer does the device get? And so they behave like the small devices don't get that much longer even as you compress them, but the big device does. So if you're going to try to put a 31 or a 35 in, you got to have a lot of depth. And that's one place where Amulet, really comes in handy because you don't need that kind of implant depth. However, the device is different. There's 8 different device sizes. Obviously, these are really functioning like the lobe of 7.5 millimeter height. The smaller devices is a bit more rigid, I would say, and the lobe in the larger devices is much softer. One neat little thing I did was I sort of stretch this thing out in my hand, like when it's in a good position, what does it look like in terms of the measurement from the distal end screw to the edge of the disc? If it's 1.5 centimeters or less, you probably are like looking at an embolization risk, okay? But you could stretch this thing out. It could get as long as 2.5, 3 centimeters from the distal end screw to the edge of the disc, depending on where it's positioned. But even with that much length, the device is still much more proximal. So during the implant, you're not really monkeying around with the distal appendage that much, or you shouldn't be. Now, one of the finer points about measurements is this is down to like millimeter differences depending on where you angle the landing zone, and some of this is experience, and some of this is trial and error. I think a lot of us have sort of figured this out over time. Like, you could possibly put a decent lobe here. Here's where the actual measurement was for being in line with the disc, and then or you could put a deeper implant potentially right there. So there's a lot of nuances to the sizing, which generally takes more brain power than it does with Watchman. So similar thing here, relatively elliptical. This orifice measured up to 15 millimeters in one dimension, 25 millimeters, landing zone, 25 millimeters in another dimension. So, you could go as big as a 25 device, but it's probably going to be pretty huge for that. You could probably go down to even a 20 device if you put it deep enough. Probably use 3 or 4 different devices to close this appendage, but it'll affect where your final disc position is quite a bit. It takes twice as many steps to implant an Amulet. Watchman comes, no assembly required for the most part. VersaCross connect, boom, boom, you're in, device is in position, and you're out of there in 10 minutes. You can do that with Amulet, but you have to really trust your measurements. Pre-procedure imaging is essential. You could know your device size very accurately with a good CT and on-table TE before you stick. Then you could have your device prepped and ready along with the sheath, And that cuts a ton of time intraprocedurally. So again, Amulet's a two-part device, means you need to use both half of your brain when you're implanting it. The lobe brain and the disc brain. So when you go to a ball shape with Amulet, you're basically advancing past the red line, which is our landing zone target, and not a whole lot beyond that. When you put in a flex, you can go to a flex ball and you can bury it, deep down, even here all the way back into the appendage as far as you want to go. When it hits something, it's just going to deflect and sort of flop out of the way. Once you put the lobe into position, there's take a moment, look at the shape. I like to do a lobe angiogram on every case. The top 3 in the red, probably don't want to leave those. The other ones are maybe acceptable, depends on the case. My general feeling is if the length of the lobe is larger than the measurement in your eye of the width of the lobe, it's probably too compressed and you need to downsize. The two shapes on the left are really kind of the optimal. The moderate compression with the offset screw or the barrel shape, those are the two that I really tend to go for. If it's off axis and under compressed, you're always going to get a leak around the disc or the lobe. But this same device, really same measurement and same device position, just changing it from the red line to the yellow line in terms of the landing zone, you can see the shape change in the device and much better occlusion. So lobe positioning is really angiographic. Look at the lobe, what does it look like, what's the shape, how long is it, and then verify with your TEE that you're coaxial to your landing zone. This case, the lobe looks great. Top shot is a 25, bottom shot is a 28. And what we saw here is that around the disc edge, there's a little crack of flow, and it's pretty dynamic. So, it was a totally suitable implant probably, but just for leak around the disc here, I opted to go ahead and exchange from a 25 to a 28. You can see the top angio on the left, that's the 25. You can see the flow going around the disc and the lobe just a little bit. And then the two images, the top right, that's the 25, where you can see the space opening up around the edge of the disc. Here's the 28. The disc forms its much more martini glass shape, and it's total occlusion. Lobe is in the same position, better occlusion by picking a bigger device to get the disc to also be optimized. Tug or tension testing, everybody has a different feel on this. Probably the most aggressive part of testing the stability of the lobe is honestly when you unsheath the disc itself. So that's pulling back towards it quite a bit until the disc is fully deployed. Tension testing is more of a pull and hold. Try not to push the cable too much. Maybe this is one of my earlier cases on the right. Maybe push a little bit too much with the cable at the end there, trying to squeeze it up on the atrial wall. You don't need to do that. It's going to find its position. If the lobe is anchored and in line with the neck of the appendage, the disc will follow. The wiggle method, with flex, you can get kind of crazy aggressive. You see people pulling really aggressively to see if this thing is anchored. And generally, that's to be avoided for the most part. With Amulet, I would suggest you don't need to do a lot of wiggling. There's some concept that you might destabilize the wires of the device. The other part of about to release or after release, sometimes the disc is sitting on top of the ridge and then pop, after you let it go, it tucks up underneath just because everything's dynamic and it slips below the PV ridge. There's not much you can do after that, but you just want to manage that in your mind that this may be a patient at higher risk for a DRT in that little crevice, when there's a tight angle between the PV ridge and the top of the disc. Close versus pass, they've got their own criteria. Yesterday we talked about, should we change close to closet or to lose? I don't know, there's different things. Pass is just sort of pass. Everybody knows what that is. It's fairly simple and pretty good guidance for when to deploy the device. Post-implant drug regimen, flex versus Amulet. It's kind of all over the place, to be honest with you. You could do DAPT with both. There's some evidence to support SAPT with both. Of course, the more we think about it, really what you're trying to do is prevent thrombus. So probably if you had your druthers and the patient could tolerate it, anticoagulation is probably better in the short term after implant. But ultimately, we're trying to get to the point where the patients are all on a single antiplatelet therapy only. And my final comment is this, is that really what we need more with Amulet is big data, but we have to have, of course, big implant numbers to get to that. The SurePass data looks great with Flex, and hopefully we can replicate that with fewer leaks with the amulet. Thank you.
All right, good morning, everyone. So this is the session for fundamentals. So my job for the next 20, 30 minutes is to talk about how imaging is different, whether it's with TE or ICE, for amulet. So what we'll do is talk about how do we plan for a optimal transeptal, how do we size for an optimal implant, and then how do we make sure that we stay away from neighboring structures that could result in complications and such. So when we think about transeptal, I think the focus, when you think about it, is you have to understand what the spatial relationship of the fossa is with your left atrial appendage, and it's a three-dimensional structure. So you have to understand that to understand what the alignment of that sheath is going to be as you cross to enter the appendage. And it comes down to, I know Chris talked about using both sides of the brain, but it does, when you think about appendage closure, you have to think of it as a three-dimensional structure and think about how rebuild that in your brain to see what this 3D structure and how is it going to respond to an occluded device, especially when you're thinking between, say, two sizes of a device. So when I think about a transeptal, I start thinking about what is my primary axis of my implant going to be. Like Chris said, you can change the direction of the lobe, and it changes how that same device is going to function. So I picked the axis that's going to give me the best seal, because we know leaks matter, and we are trying to get the most optimal implant. So, and this can be in different directions in every appendage. Now, when we think about the primary axis, we want to find that axis that's going to, give us, and you might have one or two or three options, but what's possible with the pectinates around it, what lobe is going to fit, how is that lobe going to sit, where is that disc going to sit. So all of these are taken into consideration. And most of the time, if you have an anterior lobe, that is kind of the direction we're going with the appendage and with the primary axis. And when you think about the primary axis, then you start thinking about what is the relationship of my fossa with that primary axis that I chose. And when you start thinking about imaging, I'll focus a lot more on TEE and some on ICE. We'll have other talks later on ICE. But when we start thinking about this, you're thinking about not just the primary axis. You're also thinking about the lobe configurations, the pectinate features, and also the surrounding structures. So let's look at the primary axis in two different examples. So here I've given you the appendage, the measurements and kind of the morphology in 4 different angles. And this is an appendage that has got an anterior axis because you have the appendage kind of going more towards the PA here. So it's directed this way, so that's an anterior axis. Whereas this appendage is got more of a posterior axis because you are looking towards the LV. So it's a simple way of kind of thinking of an anterior axis or a posterior axis, and it makes a huge difference as to where you puncture the septum. I do like to put this in perspective as well. When you look at this image over here, why do we use ariocaudal and ariocrani for implants? We know that when the high angles in your TEE, the 135, is kind of where you get your maximum osteal dimensions and such. So when you take that TEE, which is here, which is 135, and kind of flip it around, that is what your ariocaudal image is. So you're replicating your 135 image on a fluoroscopic fashion. In the same way, you're looking at kind of that depth in your ariocrani, which is your 45, you're flipping it around, and that's what you're seeing in your ariocrani. So kind of putting things that in perspective. Now, when we start thinking about this, the septum, there are 3 structures that we look for when we image. One is the SVC, and you're looking at, this is the bicaval view, and you're looking at the SVC. The second thing is the IVC. So again, this all changes in how your lab orients your bicaval view, but in my lab, I like SVC on the left and SVC on the right and IVC on the left. And the third structure is the aortic valve, which you get by either explaning or biplaning that bicaval view. And once you have that, you kind of have an idea of what's anterior, what's posterior, and then you can decide which direction to go. The idea when you're trying to get that transeptal is to try to be most coaxial. So you're trying to get into the appendage in a straight fashion. And sometimes once I tend, I'll get into this short axis view at 45 and optimize it where you take the aortic valve a little bit off and you can kind of see whether you're pointing towards the appendage or not. And if you go live 3D, which 3D TEE has played a huge role in my appendage cases because it is a three-dimensional structure and you want to see it in 3D. So it kind of tells you whether you are coaxial or not. Now, when we start thinking about transeptal, there's two aspects to a transeptal. One is the height of your approach, and the other one is the trajectory. So when you start thinking about the height, you're talking this plane. This plane, so there's superior, there's middle, and there's inferior. So that's superior where it kind of comes closer to the SVC, then you have inferior and your mid stick. So you have to decide whether you're going to go superior, mid, or inferior. I can just about tell you that it's not very common for us to do a superior stick. You can see this is more superior, this is more inferior. I would say this is more mid rather than superior because most of the time if you're superior, you're closer to the pulmonary vein. And here you can see this is an example of a superior stick, and more than likely, it's never going to be oriented right. So that's why most of the time we try not to use a PFO. We try to make a proper transeptal when we try to do these cases. So when we think about the trajectory of the approach, so now we're talking not superior, we're talking in this plane. So when we talk in this plane, now you want to come to that short axis where you have your aortic valve. Anything closer to the aortic valve is anterior, and away from it as you go is posterior. So you have more anterior there, then you have posterior, and then you have mid. And so you are trying to figure out what is going to be my ideal location. And most of the time, you're deciding that based off of how the appendage is, what that primary axis was that you selected. When you look at the septum, and when you start looking at it in a three-dimensional fashion, whether it's 2D, 3D TE, or 2D, 3D ICE, you are, again, trying to find both the height and the trajectory. And so that's important when you're looking at ICE, you're looking at that, you're looking at TE, you're looking at the same thing. I will say that when you do transeptal, most of the time you will get away with more of an inferior and mid-stick because your appendage is usually in that anterior fashion. Right? But then there are other appendages such as a very, very acute anterior chicken wing or an anterior curve to the appendage, or a posteriorly directed appendage, which usually require a different approach. I will say that if you have a really acute anterior appendage, you almost have to come really low. And to come really low, you have to come anterior. So it becomes a more inferior and anterior stick. And if your appendage is more posteriorly directed, then you kind of have to ride up a little bit high on the septum. So it's usually a mid stick, and then you might have to go mid or go a little bit more posterior to get into that appendage. So now talking about the transeptal, we talked about the different ones. So most of the time, as I said, it's an inferior mid approach. But this is an example of, as I told you, this is an example. This is a posteriorly directed appendage here, and when you have that posteriorly directed appendage, you are trying to come in a fashion that's more mid or mid posterior. How about a very acute reverse C, which is an anterior appendage? If you did come in an inferior, mid inferior posterior stick, this is the angle you're going to reach, and that is not the axis that you want to come in to implant an amulet. And so traditional stick is not going to be enough. You almost have to come, really in a fashion where it's going to direct more towards that anterior lobe. And to come come in that direction, you almost have to come really inferior. And sometimes you can't visualize that part of that septum on a TE. And that is where sometimes, even if you're doing a case with TE, you might have to pull out an ICE catheter. And why is that? Because if you think about the septum, that's kind of the part where you are looking for most of the time. And then the question is, if you have to go really low, how do you get to that part, right? So you are trying to get to this part, which is more anterior and more inferior. And you can see why we have to come anterior, because that's the only part that's low. So when you think about TEE, the planes that you are imaging are this SVC, IVC plane, and you're doing this bicaval plane and explaining it through the aorta, you're missing that low part, and you can't really visualize that part. Whereas with an ice, you kind of get to that lower part of that septum, and you can pull it down really well, and you can see how low you can come with the ice, especially in a really large left atrium. Sometimes you actually have to do this. So regarding imaging and what you look in imaging, whether it's TE or ICE, I mean, there are the basic stuff that you look, whether, you want to rule out existing effusions, and I'm not going to go over those things, but, other reasons for stroke, like PFO. Is there contraindications like a thrombus or endocarditis? Look at the mitral valve function. Look at left superior pulmonary vein. Look at the anatomy, obviously, of the appendage, and then do measurements. And so we'll go over some of the measurements of how we get to an amulet implant. There are 3 key measurements that you do, and Chris showed very well how these measurements are very different than what you would do for a Watchman implant. The 3 main measurements are, the number 1 is the orifice of the left atrial appendage, which is the line that you draw from the pulmonary ridge to the circumflex. And then the second one is the depth, which is this, not the depth of the appendage, but the depth of that primary axis that you picked, the depth in which the orientation in which that disc is sitting. And the third one is the dimension of the landing zone, which is where the lobe is going to sit. I do want to take a moment and tell you what this means to the device. So when I imagine the amulet device and when I do my measurements, this is what I'm thinking about. So that measurement that I do for my orifice is going to tell me how my disc is going to sit. And the measurement I do for my landing zone is where the middle of my lobe is going to land. And that's a concept that you have to understand. When that's not where the front of the lobe is, it's the center of the lobe. So that's why we ask for the lobe to be 2/3 past the circumflex. So let's look through the exercise of doing a measurement. So this is a case that we recently did. So you can see, we'll look at that. Usually you go through the 4 angles. Now those numbers are fluid in my lab. It's somewhere in the 0, 45, 90, 135 range. But you're looking at the largest dimension. And you can see I start with the orifice. I drop about 12 millimeters down, which is the waist of the device. And then I'll draw a landing zone. And I'm super careful where that landing zone is, because I will make sure that that landing zone is being measured past the circumflex, because that's where I want my lobe to be. How about, the 135, which is usually a little more difficult one to sometimes measure. In this case, we got real lucky with seeing what the orifice is, and you can see we'll throw the orifice there. But remember, the circumflex is sometimes in more of a longitudinal fashion in this this orientation. So you have to be careful as you plan the disc. Now, what I do make sure that as I'm measuring, I will look and see where that landing zone is measured. So very, very valuable that you spend that time looking at the measurements your imager is doing, or do it with them so you know what they are measuring, because that's where you expect that lobe to land. And if you don't think you can land in that part, then don't measure there. Because if you cannot land there, then what's the point? So here are the measurements. So you can see we'll do the measurements in all 4 angles, both the orifice, the landing zone, and the depth. And then you're looking at optimal sizing, and we have a talk on that, so I won't spend a lot of time on that. How about this? This is a different way of thinking. So you can see the pulmonary vein ridge is very long in this patient, and most of the waist of an amulet device is either 7.5 or 10 to 12 millimeters is all you can come down. So if I start measuring 10 down, that's not going to work. So I didn't drop that 12 millimeters down. I just did my lobe measurement, and I did a depth. And then I went back, and I went back from the lobe to see where is my disc going to land. So I'm going in with the expectation that my disc is going to stay below the ridge, because I don't think I can put that disc on top of the coumadin ridge, and that's okay as long as you don't leave an acute angle. So you set your own expectations, and so it doesn't look like you're trying to recapture, trying to put the device in a more proximal position where it's not even possible. So this is why I think getting that time with the imager is very, very, very important. 3D measurements are also extremely important because, as I said, there's a rare thing to see an appendage that's round, and I actually got a round appendage to show you, but that is not what you will see. It's almost Most of the time, it's an elliptical, oval structure, teardrop, all kinds of shape, never usually a round structure. It's a good day when you have a round appendage because you can actually close with a round device, and you don't have to worry so much about sizing. But a three-dimensional, an NPR reconstruction is very, very valuable when it comes to sizing. And it's the same thing that I'll go through the effort of actually sizing with 3D NPR and trying to figure out where my landing zone needs to be and what my measurements are. So I'm really looking at it in a more three-dimensional fashion rather than just 4 measurements and trying to get the best out of it. So this is kind of looking at the surrounding structures, and so we'll always measure the pulse Doppler within the appendage to see what the contractility of the appendage, especially a patient in sinus rhythm with a very good contractile appendage. You want to be careful about what lobe you put in and how much compression you leave, and then I also measure the pulmonary vein velocities, so I have a baseline before I get in there. And this gives you kind of a three-dimensional structure of the nearby structures. So we'll measure, if it is, say, too close, this all comes up. Now, I don't always do measurements like this, but these are things I pay attention to, is how far am I from the pulmonary vein? I look at how far am I from the mitral valve. So, because all that is going to affect how big of a size of a disc I'm going to pick. Can I oversize? Is that going to affect the mitral valve? So these are all things that you have to decide before you open the packet. Now, the other structure that I pay very close attention to is the pulmonary artery. The pulmonary artery has a relationship with the left atrial appendage. 20% of the time, the pulmonary artery is in what we call a type 2 configuration, where it is very close to the proximal part of the appendage. And when you have the PA very close to the appendage, you have to be careful about manipulating within the appendage, as especially look at this case where there's really no transverse sinus space and it's really close. So you have to be careful. And it doesn't mean that you can't put a device. It just says you have to be cognizant of it and stay away from that aspect of the device. Now, that's is in 20%. About 80% of the time, it's usually away from the appendage or away from the proximal features of the appendage, which is where we usually implant the device. And there are limited views that you can see this, mainly in the 135 view, and in the 45, if you actually rotate around, you kind of get that angle of how the PA orients within the appendage. Better appreciated on a CT. This is just 2 examples where you actually have one where you have a little bit of distance, even though it's proximal, and here that you have no distance. So very different implant techniques in both, and how much oversizing I will allow. Regarding the implant procedure and imaging for that, it's very important that as you do the implant, it's not just a fluoro guided procedure. There's imaging that plays a big role. Usually it's a 45 X-plane view for me, where I can really see the orientation of my sheath and orientation of the deployment. So, and that kind of gives you an idea of whether you are staying in that primary axis. And here we are deploying the lobe of the device, and you want to make sure that you are in the triangle configuration. You can see I'm in the back end, so I'm having a little bit of forward force there. And as I come into the lobe, I clearly can see whether I'm 2/3 past the circ, and then I will do the assessment to make sure that I am 2/3 past the circ. And before I go into the disc, like Chris, I also do an angiogram, and I will, while I'm getting prepared for an angiogram, I will quickly have my echo physician kind of look around, look in all angles to make sure that that lobe is 2/3 past the circ. Because if that lobe is not 2/3 past the circ, that's going to be a problem and result in embolization. And once you put the disc, it's sometimes hard to see the lobe. So this is a good time to actually check for your lobe position. Once you are in the lobe configuration, as you bring that disc down or unsheath the disc, that is the highest amount of pressure you're going to put on that lobe. It is the best kind of tension test you can give the patient, and you want to watch that lobe very carefully as you're doing it to make sure there's no movement, and you want to do it in a biplane view. And I usually have them cine it and save a larger loop so I can go back and review it, make sure there's no displacement of the lobe as I'm doing that. We'll do a tension test. And again, we're looking at the same. We're looking at the lobe and the position of the lobe, not just on fluoroscopy, but also on TE. So biplane imaging for that. Once the disc is out, we'll do color imaging again as we do the angiogram to make sure that that disc sits above. If that's how I measured it, that's where I will plan for it. We'll do the imaging in all 4 planes again. It's not a single dimension that you're looking at. You can have leaks in, no leak in 3, but a minor leak in one of the planes. You will sometimes see this. This is the fabric inside the disc, and there's nothing to worry about. This is just that fabric that goes within the mesh. And this is it's a tension test, and that's when you usually see it. I almost always do a 3D after the disc is out. There's really no point. I would not assess for leaks in 3D because you can't really see past the disc. But 3D is a great way to look for proximity to surrounding structures like the mitral valve and the pulmonary vein. So really good to look at that 3D, and a great picture to give you referral docs. Now, just quick on the role of ice and where ice plays a role. To me, the ice is something that you get familiar with. If you are early in your amulet career, I would say stick with TE so you can focus on the amulet. But if you are a ice pro, get into it, and you can definitely do it. I usually do a single transeptal approach where I retain a wire and get my ice catheter across through the same transeptal. You could actually do it with a double transeptal approach if you want. You have the luxury of doing it under moderate sedation or local anesthesia. If you want to do ice, I still do general, even if I'm doing ice, because I like it. And there are some patients that don't want general, and I'll do ice. But usually it's a double axis, and as I said, I'll retain the wire and get the ice catheter across. But when you're looking at ice, people ask me, well, what imaging am I looking at? It's less imaging. But the way I look at ice is you're depending on other anatomical structures in the heart, that's going to guide you what you're looking at. If I see an aortic valve on my view, that is more closer to a 45. If I see the mitral valve, that's more closer to a 90. If I see the PA, that's more my higher angle. So that is how I decide what view I'm looking at. So these are some of the views that we'll see. Again, this is the mitral valve in the middle section there. You'll see the far left here is the aortic valve view. And then you have the view that shows the PA. But this was just I don't use Cardo for my amulet cases, but this was just an exercise to just show what am I looking at with ice. So this is where, as I'm famming, you can see my ultrasound plane, I'm in the mid-LA, and I'm famming through the mitral valve, and that's one view of looking. That's a mid-LA view to look at ice. This is the next view where we will look through what we call a transmitral view or a real low atrial view, where you actually will fam through the PA, and then you have a view that you fam through the pulmonary vein. So when we start the procedure, you want to rule out thrombus. And with ice, to rule out thrombus, if your patient's not fully anticoagulated, you're looking at going into the RVOT, and you'll get that view of the appendage from the right side. And you can do some basic measurements, but that's not really enough. And then you obviously move on to your transeptal. Again, we talked about those techniques. But ice is really superior when it comes to transeptal. Regarding crossing, I usually put a loop wire, or you can put a J wire in the appendage, and then what you're trying to do is trying to cross into the LA through that same. So what happens here is we'll go with the transeptal wire, and then you'll watch on ice as well, but we'll dilate the septum, and then I'll cross with the ice catheter into the LA. And you'll see that on ice. So, but basically there's 3 orientations that you're looking at. You're looking at what I call the home view, which is kind of the 90 view, where you are running into the mitral valve. It sits, off of your sheath. You can kind of keep it in the mid-LA. You can implant in that view if you want. I like to implant in the transmitral view, which is the worst view. If you have a bad thing, it's going to show it there. So I'd rather know right away. So I usually will keep my eyes in that mitral annular view and look at the appendage in like a reverse fashion. In that way, I can see if I have good closure. So this is how the views are. So as I said, you can sit in the pulmonary vein and look at the appendage. That is the LSPV view. You can even take it into the LIPV and look up. That's a low left atrial view or from the LIPV. once you have that, you can do your measurements. Now, I don't rely on 2D ice to get measurements. If I'm planning on a 2D ice case, which is not happening anymore, I usually always have CT pre-planning. If I'm planning on a 3D ice case, you have the luxury of not having to do a lot of pre-planning. But you're replicating those same measurements, whether you're doing ice or TE. Now, the next view is looking at it from, as I said, from the low LA or the LIPV, and you don't really see many anatomical structures in that view, but it's a more close view of the appendage from that LIPV. The mid-LA view is the view where you're sitting in the mid-left atrium and looking at the appendage where you are going to run into the mitral valve there. And when you do that, you again, same thing, you run through the measurements. This is probably one of the most important views, is the transmitral view where you're sitting at the mitral annulus and looking up. When you're using a 2D ICE catheter, you kind of have to rotate it around. With a 4D ICE or 3D ICE catheter, it is more flexible to get these views a little better. Even if you use a 3D or 4D ICE catheter, you still have to get into these 3 positions, because it doesn't, you can't just put it in one position and say you get the full 3-dimension of the appendage, because if you think about 3D TE versus 3D ICE, the 3D ICE catheter has much less number of crystals, so your view plane is still small. So you still have to move it to all these 3 locations, but you get a more 3-dimensional assessment of what the appendage looks like. And this is kind of what the appendage would look like in that transmitral view. You're seeing a reverse. I'm sitting in the mitral valve. You can see the circ here. This is the pulmonary vein, and you can clearly see when you actually implant the device. And again, you can do those measurements and confirm. And again, you go through the same steps. Again, I'm looking at my sheath orientation. I'm looking at my lobe. I'm looking at how the disc is sitting. All that is pretty much the same as what you would do for a TE, just looking at it in a different fashion. This is a patient that, I measured the disc to sit outside, because I had the option, and it was tucked under, and as I did the tension test, you can see how the disc kind of sat out really well with that tension test. So you go through the same maneuvers whether you do TE or ICE, and you do go through the closed criteria. You make sure that that lobe is 2/3 past the circumflex, that the lobe is compressed, which is usually a fluoroscopic indicator rather than a imaging thing. Your orientation is something that you see on imaging and on fluoro. Separation is definitely something you see mostly on fluoroscopy, less on imaging, and the elliptical disc is seen on both. You don't want that disc to be flat. You don't want that disc to be in a V shape. Both are bad. The flat tells you don't have enough pull, enough compression on your lobe. The more V it gets, it means you are too deep with that lobe, or you too much compression, too much pull. Both are bad. Again, just kind of reiterating the ICE views, the 3 views. You can see that where the ICE catheter sits. This is the kind of the mid-atrial view, the mitral valve view, and the pulmonary vein view. 3D ICE kind of brings a little more quality to it. You can kind of multi-plane. You can cheat. It's easy. You can park it and then move on with your day. It's kind of easier. And I tell people I'm lazy, so I use 3D ICE. But you can get a nice multiplanar reconstruction with 3D ICE and kind of see all that, see the lobe, see the ball. You can understand what the orientation of it is. So you kind of get that biplane imaging with 3D ICE when you're implanting the device. So you're not just checking this on fluoroscopy. Again, same steps that you go through, whether you use 3D or 2D, you have to rotate and look at all the 3 planes. You can change the orientation of your ICE imaging in that 3D catheter, and so you get a better analysis of things like leaks compared to a 2D. So I do believe that you have a much better analysis of leaks when you look at the 3D catheter compared to a 2D catheter. And then back to, again, looking at that disc, making sure, checking your proximity with neighboring structures. Now, we go through the steps of close, and I'm going to skip through this because we kind of went through, but we look at the close criteria before we release in all 4 angles. We make sure that, that we have all the criteria met. We try not to cause or skip things if possible, because I would say if you skip certain ones, you're more likely to have an embolization than the others. But still, we try to make sure that we go through every single one of those close criteria. Okay. So I want to summarize by saying that, number one, you want to make sure that you find that ideal transeptal location, so you're coaxial, so your implant can be successful. My threshold to restick is very low, but I try not to by taking my time to find that right transeptal location. You want to make sure you measure, you put the effort in measuring with your imager so that you don't, you know what you're setting yourself up for. If you do pre-planning, that's great, but combine it with your intra-procedure imaging to get your best outcome. Pick the device that you are going to be able to implant to what measurements you made, and look at the neighboring structures, look at the compression, look at where your anchors are going to be to get that most safest implant, and then you can use both heat and ice to complete your implant. Thank you.
So I was given the task of talking about what is the clinical relevance of device leaks. Right, these are my financial disclosures. The first thing I want to remind everybody is when we implant these devices, it is of paramount importance to know, or at least remember in our heads, that Amulet is not a Watchman device and the implantation procedure is completely different. And so we really have to treat these devices very differently. Chris did a fantastic talk really alluding to all the differences, and I think that really makes a difference. So what exactly is a peri-device leak, right? So in its purest definition, active unprotected communication between the left atrium and the left atrial body presenting beyond the left atrial appendage occluder is a peri-device leak. So the entire idea of left atrial appendage occlusion hinges on the idea that you put something into this left atrial appendage so that you can prevent flow forwards and backwards, and then making sure that the device hugs basically the walls of the left atrial appendage or the left atrium, right? That's the fundamental premise on which all of these devices are built. But then the question is whether these devices can actually perform the promised action or not is this the next big question. So a lot of times we get confused about whether an appendage is leaking or not, because when you really talk to your CT imaging docs, they oftentimes describe a very complex process of whether something is a leak or not. By the end of the time you read their report, you yourself are confused because you really don't know what exactly it is that they're trying to describe, right? So this all goes back to the permeable left atrial appendage versus a non-permeable left atrial appendage, right? The non-permeable earlier versions of the device, you could not really see the contrast going across at the time of the implantation. So as the devices evolved, we embraced a more of a permeable device, thereby the implantation process could be better visualized, and the devices could be more compliant, and then the stability assessment is actually much better because you can see exactly what's going on. And so it has a very similar ability to prevent clot out of the left atrial appendage. Chris actually showed that very nice experiment that really makes that point. So what's a good closure for an appendage occluder, right? Yeah, we need stability. Of course, it can be met by the close of the pass criteria depending on whichever device that you use. You want a circumferential contact and then no obvious visible gaps between the wall and the device. So how do you exactly assess the closure during the procedure, right? So the two standard things that we use is obviously fluoroscopy. It can mostly discern a true gap, a peri-device leak. Sometimes you really cannot tell the true contact with the tissue, and it's sometimes hard to really see that small peri-device leaks. And that particular aspect of fluoroscopic dependence can be corrected by using the ultrasound. So traditionally, transesophageal echocardiogram has really established itself over the last few decades, and we have established angles, workflows, definitions, and we have tremendous amount of expertise in this, right? And then it's very possible for us to actually see and discern the true gap in the peri-device leaks. We can most likely not see the blood flow through the device, but then the flow around the device can be very well established, and that's the reason why a true peri-device leak is a lot more easier to look with an ultrasound-based imaging, either an ICE catheter or a TEE, and it has really become a gold standard in the implantation process. So what exactly does it mean to have permeability across the left atrial appendage? On the transesophageal echo, during the follow-up, especially this particular issue comes up when we're doing follow-ups, is TEE a better imaging modality or CT a better imaging modality, right? So if you look at the TEE, obviously it doesn't require a vascular access, and there is a lot of conventional expertise in this. And then easy comparison between the intra-procedural images and then the images that you're going to get. And of course, there are blind spots in this process. What you see between 0 to 45, 45 to 90, and 90 to 135, there are obvious blind spots that sometimes you obviously are limited by it and you can't pick up on that. And you can't confirm endothelialization around the device with great confidence. And thrombus definition sometimes can be gray as well. So you switch it forwards and use CT angiography. Obviously, it's non-invasive, exposure to contrast and radiation. Most of the times, there is no baseline for comparison post-implant. So you are basically going by whatever you're going to see at the time. And of course, there are no blind spots because you can really look at the ostium of the appendage in 360 degrees, and you can delineate the neo-endothelialization in a surrogate way. And thrombus definition obviously is going to be a lot better with that. So those are the gives and takes. And the problem that you're going to have is this concept of intra-device leaks. So that is something that I think we got to kind of acknowledge and then try to see, to be able to differentiate whether it's a true peri-device leak versus a mere problem of endothelialization. So on the TEE, you have a standard definition for peri-device leak. It's a singular definition, a visible gap in communication. You can have single jets or multiple jets, and it's well tested. We've been talking about these peri-device leaks for a very long time. And so, and then we have also established that peri-device leaks are oftentimes associated with systemic thromboembolic events. Then CT scan really becomes murky. This is where my brain really freezes when my CT imaging doc tries to describe whatever they want to describe. And in a way, some of these early definitions that come up, I'm not trying to poke fun at this, but I think the impracticality of these definitions is what I wanted to raise here. So PDL is the same as a TEE. Intra-device leak is merely contrast flowing through the device into the LAA body. And then you have a mixed leak, and then you have a patent appendage with a visible leak, and then a patent appendage with a non-visible leak, and then a non-patent appendage. Come on, this gets a little too much, right? So this really needs to be simplified. So the CT-defined leaks, the implications of the non-PDLs are really largely unknown, right? So I mean, I'm specifically referring to one particular paper here. And then the non-patent appendage is really the best case scenario, right? You put the device in, it's completely endothelialized, and there is no evidence of the appendage, there is no contrast going across, so that's the best case scenario. The ideals and the panwells are really the same. It simply shows that there is incomplete endothelialization, and that's all what there is to it, and it really does not have any implications to systemic thromboembolic events or any other subsequent events. So what exactly is a significant leak? I mean, that has been a moving target for all these years. And how in the world did we come up with this 5 millimeter cutoff? Nobody really knows a good answer for that. And I think I blame my esteemed colleague, David Holmes, for that, because when a decision was made to really figure out what really could be considered as an important leak, I think everybody agreed upon 5 millimeters. It's small enough, so that's good enough for us to really move on. That's how most of the data really comes up, and we accepted that as an industry gold standard for the very longest of the time. But then as time moved, as we got better at implanting these devices, as the devices really got better, our standards also got better. So I think it is probably safe to say, instead of really using a cutoff, it's probably important to basically grade the leaks depending on how big they are. So at least in our case, we call anything less than 1 millimeter as clinically non-significant, 2 to 3 millimeters as mild, 4 to 5 moderate, more than 5 millimeters as a severe leak. So that's kind of really dissecting it, but this really helps us to be better implanters, and really endpoints could be significantly improved upon. So endothelialization obviously takes time. It may not be complete in all the patients in 6 weeks or even 6 months for that matter. I mean, we come across patients that have a non-endothelialized device even after 12 months. So there is really no definite connection between lack of endothelialization and a systemic thromboembolic event or a DRT. That's something I think we all have to be feeling comfortable about. There are many factors that determine that, and that includes genetics, mitral regurgitation, whether somebody is in sinus versus long-standing persistent atrial fibrillation. the surface area of the left atrial appendage occluded itself, and that's the reason why when you put in an amyloid device, the disc actually has a relatively large surface area, and so it's any device that has a large surface area is really going to take a much longer period of time for endothelializing. So that's the reason why oftentimes you come across a scenario where the amyloid contrast flow goes through, suggestive of lack of endothelialization. And then obviously contact with the left atrial appendage wall is very important for the near endothelialization process to continue. So this is the amyloid data at 45 days and 12 months. This is the PDL severity by the TEE. So what you see here is actually pretty impressive. Leaks that are more than 3 millimeters, right? It's 11% against 26% at 45 days. And perhaps these leaks do get better because of adjustment of the device and cardiac action and endothelialization. And then that at 12 months is about 10% versus 21%. So still, we can argue that this is an old Watchman 2.5 device, so that's the data that we have. So a dual seal mechanism device versus a single seal mechanism closure device, obviously a dual seal closure mechanism device has a significant superiority in efficiently closing appendages with a smaller percentage of peri-device leaks. I think that is conceptually very well established. So in multivariate analysis, obviously the Watchman 2.5 device was associated with a 2.7-fold risk of moderate PDLs at 45 days, right? So that is a consistent pattern that we have seen from time and time. So this is one study, I think that really, the Swiss APRO very clearly showed that more than 65% of the patients actually had some sort of a patency through, right? So what is really relevant in this particular case is the PDL or the mixed leak, where the amyloid device has at least a 50% lower chance of having a leak than it was with the Watchman Flex device. So again, it's the process of the evolution of the devices and the evolution of the experience of the operators, and how much more better we're actually getting with the implantation process. The leaks are becoming increasingly less and less problematic. So this is one interesting paper, which is called the Seal Flex device, right? So on the front face of it, when you really look at this particular data, it looks like the Watchman device has a much better occlusion than the amyloid device. It's like, wow, it's 72.6% versus 27.4%, right? Then what you really look at it is a lot of this leak is primarily defined based on a CT scan, where a significant number of intra-device contrast flow-through has been accounted as a leak. So what really matters there is the true peri-device leak, which is obviously dramatically better in the amyloid device than it is with the Watchman Flex device. So this is, I think, something, again, one has to take into consideration. So let's talk a little more about the clinical impact of the leaks. So many of us came to believe for many years that somehow leaks actually don't matter, right? The very first paper that came out of the Protect Prevail study, combined data, suggested that perhaps there is no correlation. But we haven't had followed these patients long enough. We haven't had done enough of these cases to really show that the peri-device leaks actually matter. So the current data, if you really look at the 18 months follow-up of the amyloid data, there is a significant correlation between patients that have a significant leak in terms of systemic thromboembolic episodes, cumulative events of stroke, cardiovascular deaths are much better when your peri-device leak is less than 3 millimeters. I think that's undisputable. And there are multiple studies that subsequently came up after this. So peri-device leaks are obviously associated with more embolic events. You're looking at 1.8% versus 3.6%. And then you see that and it applies for both the devices. So all across the board, whether it is an amyloid device or a Watchman device, if you have leaks that are more than 3 millimeters, that means there are implications to that. So we talked about this data early on. So the early evidence is, in fact, it comes from Chris Ellis's work where they systematically looked at leaks. So anytime you have less leak, the performance is much better. Presence of a leak also leads to more interventions because obviously you don't want to sit on those things. So whether you ablate it, you coil it, or you plug it with a vascular plug, there are several approaches that you'll be learning later today from Rodney Horton. And then the NCDR LAA registry actually had some very interesting data, right? That means if you really compare those with very large leaks versus small leaks versus no leaks, the clinical significance was between those that had a small leak versus a no leak. This sort of sounds a little bit paradoxical, isn't it? I mean, if you think that patients with a larger leak should have much more worse outcomes than it is patients with small leak. I think the paradox here is essentially coming from the fact that a large number of those patients that have large leaks actually ended up being back on oral anticoagulation. So these patients have been re-anticoagulated. And that's where the data that Lars showed early on, at the end of 3 years, 7.6% of the Watchman patients actually ended up going back on anticoagulation against 3.3% of the amyloid patients. And perhaps this explains the so-called paradox that we talk about. So the further confirmation of why leaks matter, right, the longer-term outcomes. Look at the 5-year follow-up data, right? The adjusted 5-year rates of ischemic strokes and systemic thromboembolic events at 1 year versus at 5 years. Obviously, the presence of a significant leak leads to worse outcomes. So how exactly does it happen? I mean, is it mostly just because the device is off axis? Did we miss the lobes completely? Was there a micromigration? So these are all important factors that one has to take into consideration, and this is exactly what we looked at with the Amulet and the Watchman 2.5. And what you see here is there were 32 patients in the Watchman arm, and then there are 10 patients in the Amulet arm, and we tried to categorize these people for these particular categories of why they could be having a leak. As it is very well evident, when you have a very large proximal lobe, it is hard to close those proximal lobes with a Watchman device. So you are basically struggling against a big overhang versus leaving that lobe wide open. Many times, intraoperatively, it looks like you have gotten a good coverage of this proximal lobe. But when you follow up these patients in the follow-up times, because of the micromigration or movement, oftentimes that coverage around the proximal lobe goes away, and as a result of which your proximal lobe gets exposed. So these are the nuances that one has to take into consideration. And a dual seal mechanism, that is the biggest advantage that I see that the disc provides, the ability to successfully close at the level of the ostium and then being able to close out those proximal lobes, I think, is what gives the Amulet the specific anatomic advantage that the single lobe closure mechanism devices do not provide. So when you analyze this further, what anatomic factors are really predicting the peri-device leaks? So we systematically looked at the orifice diameter, the landing zone diameter, the depth, ovality index ratio, whether it's a chicken wing or it's a multi-lobed LAA. What really stands out in the case of Watchman is whenever there is a large orifice, and when your landing zone diameter is larger, and then you have sort of longer depth, it seems to be that the Watchman device has a higher instance of peri-device leaks. But again, this is something that we can overcome by better imaging or implantation techniques. A lot of times, peri-device leaks do get better, but in some cases they don't. So you always wonder why somebody should accept a peri-device leak of 5 millimeters at the time of implantation. I think in this day and age, with the kind of devices that are available, it is inexcusable to actually leave a leak that's 5 millimeters. And for that matter, even, I would say, beyond 3 millimeters. So the standards have to improve, and we have to redefine what we really consider something as significant or not. So the PDLs sometimes can partially resolve. So a large leak sometimes that you see at 45 days can get smaller at 6 months, and it may get much further smaller at 12 months. And sometimes they also get resolved completely. And oftentimes, these are the smaller leaks that have a higher probability of closure than it is with the larger leaks. And then you have techniques to really close some of these peri-device leaks. So greater number of adverse events and unresolved PDLs were seen with the Watchman device. So a cumulative incidence of adverse events of 6 versus 2. There were unexplained deaths of 4 versus 0. So we don't really know whether a PDL was associated with a significant embolic stroke that resulted in the patient's death. That data is not available. That's a possibility. So the adjudication of these deaths could not be made on those. So it goes back to the best practices of further reducing the PDL, which is basically understanding your device, understanding the anatomy of the patient, and then all the intra-procedural elements that go into the mix. So how do you improve the implantation success? Appropriate patient selection. I would strongly suggest that your first implant of an amyloid device should not be a Watchman failure, period, end of the story. Because most of the times you're failing to close a Watchman, an appendage with a Watchman device, and you failed at it, that means that's a complex anatomy. So don't test your skills on your very first implant with Watchman failures. So I would strongly suggest not to do that. So go ahead and get 10, 15, 10, 15 normal cases under your belt so that you get familiarized with the whole implantation process on the device and the tactile feel of it. Pre-procedural planning is extremely important, as Devi showed in her talk, and then the subsequent talks that are going to come. That really makes a huge difference. The transeptal axis, and I do think when the steerable sheath comes back into the market space again, that's really going to make a difference because that's going to help us with the coaxiality. Remember that you really don't need big compression the way you have to do it with a Watchman device. A lot of times you end up oversizing a Watchman device mostly to be able to cover those proximal lobes so that you have more device to work with so that you can overhang it at the ostial level, and thereby you can get some coverage of the proximal lobe, right? In this particular case, you got a beautiful disc that actually takes care of the problem, and that's the reason why you really don't need to oversize. Appropriate device preparation and deployment is very critical, right? So don't deploy when you are not sure about it. And the release criteria, the stability, all of that are important factors that one have to take into consideration to really have a successful implant and then potentially minimize the peri-device leaks. So if you were to ask me a question, how much of a peri-device leak is acceptable? In my mind, no leak is the best case scenario. So I think we all should try and strive towards improving our techniques, improving the devices, and everything else so that we can actually give a patient a zero leak. Thank you very much for the opportunity.
So I want to thank Abbott for the invitation, and it's truly an honor to follow such an esteemed group of speakers. My job over here is to put it all together. And, we had extensive discussions about the data which is available. We had extensive discussion about procedural implanting techniques and what we can do to minimize some of the issues that we've seen with the previously existing system. So I'm part of a system which is the Edmund Health System, which is nationwide, and we were, like most of you guys, we were prolific users for what I call as first generation left atrial appendage occlusion. And then when this system became available to us, it was a task that was given to us that whether there's a need for such a device. And I want everybody over here to think of it as a second generation. It's not too different from what happened with, let's say, ablation, when we went from non-contact force to contact force, or more recently PFA, as we're seeing, pulse field electroporation. We use existing catheters, and now there are new catheter systems coming out. So what is the opportunity which exists? And everybody knows there is need for an alternative to medical management, especially in Florida. There are complaints all the time about high costs involved with DOACs. their bleeding risks. We're dealing with older population, their falls that are happening. So the options and alternatives are there. And we all know and very familiar that left atrial appendage possibly contributes to more than 90% of the thrombus accumulation in the strokes that we see. And it's a growing market, and all the health systems commercially are actively involved in this. It's proposed to be more than $1 billion market, and it's actively growing in US. This is a question which is going to come with all of your health systems of how to accommodate some of the newer technologies coming in. And is there an unmet clinical need? And my job over the next few minutes is to elaborate that, yes, there is. With the first generation one, we were doing a decent job, but on follow-ups, we would see things like leaks, as we discussed. We would see shoulders. We just compromise with that. And is there a need for that compromise? This is the basics for this. The left atrial appendage is not a straightforward structure. There are 20%, only 20% where there's a single lobe, and you can probably put any device in there. But the 54% is up to 2 lobes, 23% is 3 lobes, and 3% are 4 lobes. So even if you're the best operator in the world, trying to fit that device to finish those or completely close those lobes is going to take a lot of time and possibly some degree of compromise. And it's not you. Sometimes it's the device. These are the courtesy of Dr. Lakkireddy, the unsuitable anatomies. And you can see, think about a single seal closure device trying to fit into that chicken wing. And some people can do it. We have figured it out. We're just so good. But it's not probably the right thing for the patient. Look at the cactus, where there's a small pectinate muscle. And if you're trying to, if you're going to try to put a standard single seal device in there, the pectinate is going to try to throw you out. You're going to live with a shoulder, and you compromise, which was okay 2 years ago, but I don't think it's okay anymore. And then you look at the windsock, and then you look at the cauliflower, where there's no depth at all. And how do you handle such situations? And if you don't get familiar with these, they are going to come. If you do enough volume, as this volume is growing, if you do not adopt, you're going to run into issues. So it's better to get prepared for this. It's not too different from what you did in ablation. It's not too different what you have to do with PFA. It's not for interventional colleagues. It's not too different from switching from one TAVR to the other, depending on how bad the conduction system is and whatnot. And the device leaks are legacy, as enough data that was shown out here. And no leak is acceptable. I agree with DJ on that. I think we have lived with this way too long. And I think there's a later talk on this in detail, but it's a disservice to our patients. And when the option was not available, I think it was okay, put them back on anticoagulation. But doing a procedure on the patient, then putting that back on anticoagulation, it just doesn't feel right to our conscience. So understanding this, understanding your patient, taking a step back and seeing what the right tool in your arsenal is important. And these are the proven clinical implications. Now we have 5-year data from Watchman, from the first generation device. 1 in 4 patients, as DJ showed in this, 1 in 4 patients had peri-device leak, totally unacceptable. Presence of around 5 millimeters, 2 times greater risk of ischemic stroke, totally unacceptable. 51% of leaks with greater than 3 millimeter. If you show this data to your administration in commercial, regardless of however strong a contract they have with any kind of company, it's not difficult to tell them that there is room for a 2nd generation device. And you need to get comfortable adopting to this device. So what does Amulet offer? Well, I like what Chris mentioned on this, that there are 2 parts of the brain that you use in it. There's a lobe part and a disc part. And there's a lot you can do as an operator on this. In the first generation, you choose a size, you put it in, and you hope for the best. Here, there's a lot of skill that you can use, which all of you I know have, to use your disc to cover whatever is left. So you use one part of the brain to cover whatever you can, lobe, make sure it's stable, and cover the rest with the disc. So you really need to think in 2 steps for these procedures. And you really don't need to go distal in these patients, and some of the techniques that we talked about. And then the dual seal technology tends to accommodate. So this is a good example, and I know in previous talks they went through this pretty quick, but if you look at the double lobe technique, you can see that one lobe is completely uncovered, right? And then we use the disc to cover that lobe. And there's nothing wrong with that, because when you bring these patients back for a 45-day TE, you will love the way that disc sits. There is no color flowing through that. And we're going to show some of our data from our institute once we instituted this. Widest ranges of sizes available, which make your options a little bit better. And then there is clinical data, which has more than 2,000 or about 2,000 randomized patients in several centers across, in which the effectiveness is really good. Safety is acceptable. And then safety is going to get better as you do more procedures. But if you do 5 procedures a year, don't expect yourself to be really safe in these cases. You need to get comfortable and familiar. Not too different from people who are cryo users versus RF. You need to make a decision in a particular patient where you want to use an RF. But if you have never used an RF in 2 years, it's difficult to go back to that. So not too different. It's just a different generation device. Okay, this is the Amulet IDE trial. Very robust data, as you see, very extensively followed with DAPT versus warfarin, and the results as we mentioned. And then what I wanted to point out is something which has been pointed again, is the PDL leaks, right? And that's something which should not be acceptable for our patients, you know, to have such degree of PDL leaks. So comparatively, if you have a device which can close more efficiently in certain population of patients, that's the device you want to have in your arsenal. And then we're going to switch quickly to the 3-year data we just got published as well, where you saw similar results with peri-device leaks, much significantly lower than the Watchman arm. So the dual seal Amulet device continues to demonstrate safety over the course of 3 years. So the question which comes in, and that's what our discussion was when we brought it to the administration. They said, hey, listen, we have a great contract with this company. I want you to only use Amulet if you're failing a Watchman. I'm like, why would I do that? So what do I use if an Amulet fails? Do I use a Watchman? Has anyone done that? No. So why would I train myself to use 5 cases? If I'm going to do this, I got to do this right. And that's how we instituted. And now we looked at our data very extensively. And now we're almost 90-95% Amulet because I don't have any headache to deal with. The other issue is that we don't rely heavily on pre-procedure CT. It's a different discussion. It's just a different workflow for us. And then if you go to the next slide, I guess I can do it. We put a catheter in there. There's a significant leak. And then if I go next, we had to put an AVP2 device to cover this. And you don't want to be spending time doing this. All of you are busy practices. You don't want to be bringing patients for that. It's just not good practice. It is playing, it looks like. Anyhow, so this is another interesting case. I have very little time, but 78-year-old with hypertrophic cardiomyopathy and AF. Remarkable case. She had, I did an ablation her a long time ago, very severe thick septum, developed AI and MR, and then had mitral valve replacement, aortic valve replacement, AtriClip placed, cryoablation, septal myectomy, had recurrence of atrial fibrillation. A cardioversion was performed, but no TE done. She was restarted in Eliquis because of that. Due to some reason, was taken off Eliquis and had a stroke. And then this doesn't happen with first generation left atrial appendage occlusion. It also happens with surgical. And this is, I hope this video plays, but if it doesn't, there is a whole gap. Despite the Amulet closure, there is a significant chunk of left atrial appendage left behind. And then we chose the Amulet smaller device to actually close that clip, and this patient has done really, really well. And these are the TE pictures. Let me jump to our data real quick. The safety and efficacy of the implant we published is submitted to the CSI Frankfurt. These are now more than 100 patients. We don't do any pre-procedure CT imaging. We rely heavily on intra-procedure TE, ICE. We feel not unlike what we do with AF. You know, we started with CTs with atrial fibrillation, but we felt that until and unless you have a strong correlation or strong registration of those CT images to your live case, there's always some degree of variation that exists. So when you're using Amulet and when you're using left atrial appendage angiography, a lot of times you were able to close with single device without having any robust pre-procedure CT or anything. So these were our first 26 results, which were published several years ago. And then we looked at bleeding complications, same-day discharge. No pre-procedure CT was used. In only 2 cases did we had to use more than 1 device. And all the 45-day post patient had a complete closure with no leaks. And one of these patients was actually a right IJ case where I had to use more than 1 device. But other than that, in most cases, you're able to close with 1 device. You don't have to open a second device. If you use your angiography skills and peri-procedure imaging TE or ICE carefully, you'll be able to do. So conclusion, Amplatzer Amulet Occluder is a safe and effective alternative to oral anticoagulation. No recorded instances of procedural complications for us, at least. If you use it, like the skills that we described before, and longer-term follow-ups, including multiple centers are recommended. Thank you very much. Sorry,
Well, thank you very much, all the speakers, and it's now time to have some questions. You can see that there are microphones on the floor, and you're also, many of you, connected to the LAAO system. Please send in your questions, and we'll be very pleased to try and get good answers for you. You want to kick off with one of the LAAO questions?
Yeah, so one of the questions that came up is the transeptal point as important with a steerable sheath? Devi, you want to take the question?
I'll take that. I believe that you still have to get a reasonably good transeptal access. The steerable sheath currently in its iteration goes in one plane. It can, I won't try to overcorrect a bad transeptal with the steerable sheath. That's not what the steerable sheath is for. It is to optimize your implant to optimally orient your lobe and your disc and to avoid core wire bias and to reach difficult lobes. That's what the steerable sheath is for. So I would not try to go through a bad transeptal and just try to get away with the steerable sheath. I think you definitely get in trouble.
Can I just ask a question to Lars? Lars, you took us through a lot of the data that's so far been collected on LAAC, particularly Amulet data. What do you think is the most important information we're waiting for? I know, of course, there are 2 basic sets of trials ongoing at the moment, the LAAC versus DOACs trials and the LAAC versus standard of care in patients who are too high risk for OACs. But what other data do you think we really need to put this therapy at the top of the list for managing patients with AF and stroke risk?
The very short answer is evidence. Because I think this is a therapy everyone in this room believes is very appropriate in these patients, but the number of patients which is actually treated is very, very low. There's a huge potential. And as I said, you can argue today there's no robust data to support it. Most of the patients who are treated are patients who have what we call absolute contraindication for oral anticoagulation. And there's not conducted a single randomized trial. Boston tried to do the ACEP2, but it was too late. It was already clinical practice. Protect AF and Prevail, randomized patient between Watchman and vitamin K antagonist, which is not an accepted oral anticoagulation today. So that's why we don't have a stronger indication in the guidelines. It's not a class 1A. It's not a class 2A, where it's something that you should consider. It's a class 2B, something you can consider. And I think if you want to convince the referral network, the payers for this, we need stronger evidence. And I think the 2 trials I'm looking forward to is, of course, the Catalyst trial and the Champion AF. I think that will, if they both come out positive, there is a potential chance to get a class 1A indication, and that will hopefully open up for the referrals of these patients.
Thank you.
So there was another question. if both imaging modalities were available, what is the best imaging modality, TEE or ICE? Individual opinion of the panelists here was what people asked for. So we'll start with you, Chris.
Yeah, so for Amulet, I do them all with the TEE. I did Flex for a while with ICE, but honestly, I found more leaks. So I do that in select cases, but pretty much TEE, I find out. We have cardiac anesthesia that does the imaging. They're excellent. And with the newer machines and the multiplanar, I mean, you can have a really nice implant and you don't have to mess with the imaging yourself.
And you, DJ?
In my case, I prefer TE for now. Number one, I don't like the 2D ICE as much. And obviously the 3D ICE really gives you a lot more flexibility. The multiplane imaging actually solves some of the problems that the 2D ICE imaging has, but the catheters are super expensive. So when you really wear the hat of a service line charge and not only providing greater care for patients, but the bottom line really becomes important, right? On most of these procedures, hospitals lose money. And when you introduce an element of $4,500 for a 3D ICE catheter, none of the administrators like you at that point in time. So that being said, there is an ongoing clinical trial that our center is performing, really looking at TEE and 3D ICE or 4D ICE next to each other and understanding some of the limitations. One point that I really like the 3D ICE is when you really get that transmitral valve axis, and when you do a multiplaning imaging of that particular area, the tissue contact that oftentimes is hard to see on the 135 angle in TEE is a lot better visualized with the transmitral axis view of the ICE catheter. So I think it's a journey. We'll probably get there one of these days, but I don't think anytime soon we're going to afford all those.
Usman?
Yeah, for us, very different. Even though in Florida we feel like we're spoiled, but we have a lot of pressure from administration to reduce the amount of anesthesia. So I don't have any dedicated cardiac anesthesia for TEE. Oftentimes I'll break scrub and do my own TEE during the procedure. But I'm quick on that. I just have to take a couple shots of espresso before the case. It's called Cuban coffee. But my goal in life, right now what we're doing is pre-procedure TEE to kind of get an idea. We do, for Amulet, we do a lot of angiography during the procedure in the ball mode and with the lobe deployment. And with those techniques, our sizing has been really good so far. My goal in life is to get 3D ICE in the LA. We'll have a little talk if the videos play, next one. But I think there's tremendous potential for Amulet. I'm not sure about Watchman because of the compression and everything. I'm not sure if it's going to correlate that good. But for Amulet, I think there's significant potential there for use 3D ICE and do without general anesthesia. So just propofol, keeping in mind the air embolism issues that were brought out before.
So I usually use TEE just because I have an incredible anesthesia team that is really good at giving me TEE support. Having said that, I think if you're looking at your own practice, you have to individualize it. You have to look at your experience in implanting the device first. You have to look at your experience in using ICE in the left atrium, and you have to get to the point where you get all those images that I showed where you look at the device in all those planes. And once you can get to that point, I think they're equal. And in certain views, like DJ said, the transmitral view, especially with the 3D ICE, you can get a nice MPR and you can clearly see the tissue proximity in a circumferential fashion, which is sometimes really hard to see on 2D modalities, whether it's 2D TE or 2D ICE. But I think you have to individualize it.
So if I should come with one comment is that we see that this procedure for structural heart is increasing everywhere. And it's going to be also a matter of resources. Can we actually accommodate this increasing volume? And one way to do it is to simplify this procedure. So bottlenecks are anesthetic time it is anesthesia, it is having echocardiographer who could do the TE in the cath lab. So I think one potential way forward is to streamline it, to do it in local anesthesia, to do it ice-guided. If you don't make that transition, I think it's going to be very difficult to increase the volume significantly as we move forward. And that not only for left atrial appendage occlusion, it's for TAVI, it's for PFO closure, and potentially also for TEER procedure in the future.
Yeah, going back to that, just an important comment. That's how we introduced 3D eyes, because our administration looked at the cost involved with cardiac anesthesia, general anesthesia, recovery in the room and whatnot, and compared it to the cost of the catheter. And looking at that, it's looking favorable to use a catheter, which is a little bit more expensive than your standard eyes, but saving time on the other arm. So everybody has to look at it their own individual.
So there was one question whether the use of ICE leads to less or more PDLs. I think that data is not available at this point in time. We haven't done a randomized control trial to say one is better than the other. I think we'll learn more about it in the days to come. So
I do want to recommend that if you're going to go that route, maybe start with your AF ablations for electrophysiologists. Start putting the catheter in the LA. We do that routinely to look at your lesion formation and stuff. So you get very comfortable with that. You don't want to spend 10 minutes crossing that. You want to get very comfortable how you cross from a single hole with that ice. There was one question there, I think.
Yeah, I just had a quick comment and question for the panel. When I made the transition from Watchman to Amulet, we've used a lot more contrast. I think that's been key, and I think Dr. Ellis and Dr. Nair alluded to that fact that shooting the lobe with contrast, and if you have a seal and nothing getting past the lobe, I think that's the most important predictor, because once you deploy the disc, things become very confusing with your imaging, and I think you get all those confusing terms with your CT as well. So often what we've seen is if you do a follow-up CT at 45 days or 2 months or 3 months, they'll see something, there's something going between the disc to the lobe, but nothing getting past the lobe. But if you have a proximal implant, I think as endothelialization takes over, I think you're going to be okay. So I think the shot to know that you're going to be most successful is the shot with the lobe. I mean, I want to see if the panelists would concur how important that is.
agree. I think that's a very important step. So there's now.
Oh, with a caveat. So the caveat is I just did a case of reverse chicken wing anterior. So there are 2 lobes. So you want to, and there's a prominent pectinate muscle. So if you want to try to put a bigger device, the pectinate is going to throw you out. So at that time, you use the left side of the brain, as Chris said, right? So you cover one lobe with your lobe, right, and make sure it's fully tight. And then you size your disc to cover the rest. So you got to think both ways.
So there's another question that came up with regards to the imaging. During the ball triangle lobe deployment, what is your primary visual focus to continue with each step, angiography versus 45 or 135 degree?
Okay, so I think it's a great question. So when I unsheath to the ball configuration, what I'm trying to do is trying to make sure I'm coaxial in my deployment axis. So I think about what I thought of in my head as my primary axis. I think of the appendage in a 3-dimensional fashion, and then in that biplane 45, 135, I'm making sure I'm in the plane. So I want to see my sheath and my ball, not in an off axis. Once I get to the ball configuration, it's not really the best time to gain depth, but if you have room ahead of your ball, you can maybe puff a little bit of contrast if you want through the device, or you can, if you can see well on ice or on imaging, you can actually move it forward. But then once I'm in the back wall of the appendage, you remember the current Amulet device does have the distal puck, so you don't want to cause any trauma to the back wall of the heart. So at that point, I will go into the triangle configuration. If I have to change my orientation, if I have to counterclock more, come more anterior, go posterior, I'm doing all of that in the ball configuration to get that primary axis. Then once I go into triangle, then I'm watching on my imaging and on my fluoro to make sure that the back end of that lobe is not at that point moving. I'm giving that forward force. Now the anchors are deployed. I don't want to cause any counterclock or clockwise motions. It's just a forward motion at that point. And then I'm looking at imaging to make sure that lobe lands where I drew my landing zone.
And a question for you, Lars. In the IDE trial, how do you explain the trend towards lower mortality with Amulet?
Yeah, I think maybe GJ is better to discuss it. No, I mean, again, it's a large cohort of patients, so I don't think it's patient selection bias. It must be about what we have seen with the residual, like the peri-device leak, the higher rate of device-related thrombosis, the more common use of oral anticoagulation afterwards. I have no other explanation why you see it. Even though it's only a trend, it's actually pretty close to be significant. It's 0.07 for all-cause mortality. So,
yeah, no, I agree, Lars. There is no clear-cut explanation because there is no adjudication of these deaths of the death certificates, and so the assumption, all things being equal, because it's a pretty well-matched study, the patient demographics are very similar, so it's at least an assumption to say. I don't know if it's a safer assumption to do it or not. That's the reason why we can't say it for sure, that large peri-device leaks, potential for thrombus embolizations and life-threatening strokes is a possibility. There could be many other things as it goes. There was one question that came up. What is your experience with late pericardial effusions, and is the tension test really necessary? Is this where most of the pericardial effusions occur? Chris, you want to take that?
Sure. So my experience with it, I think I've had 3 out of about 300, so about a 1% rate or so, where people show up a week to 2 weeks out with an effusion. Generally, we drain it, they do fine, and by follow-up, everything looks good. And I haven't seen any of those associated with a leak or a DRT, but there's some thought, if you have to cease DAPT early, you could set up a device thrombus risk. As far as the tension test, yeah, really, I think when you put the disc out at first, that's really your best tension test, because you have like complete elongation of the disc, right? So that's as much tension as you're going to put on. You don't pull the tension test that far when you're doing it. Otherwise, it's more just a marker of sort of time, like a little bit of time. It's probably more a little bit of tension and wait 30 seconds and watch it move, and just make sure there's not any like gradual migration of the lobe.
Well, I mean,
I don't think it's like absolutely mandatory, but I still do it.
The tension test, in my opinion, I think it's still a good way of testing the stability of the device. So what we do in our lab is, once you unsheath it, as you get the disc out, you make the football. I actually tighten the TUI and then leave it in place for about 30 seconds so that you can actually visualize on TE and fluoro to see if the device actually migrates. Especially in 135, you can very nicely see if the lobe migrates outwards or not. So if it's not, then I think it's pretty stable. At that point in time, you can release it. So the question of whether that causes pericardial effusions and puncturing of the appendage, the tension comes from the neck to the disc. So there's really not much of a tension on the lobe. It only helps us to basically give you just enough on it. You're not actively tugging on it, right? So you're merely pulling the disc out a little bit and then keeping it in place. I have a couple of theories about why people have late pericardial effusions. I think it is probably microtrauma that happens with the device, and if the anchors can cause a little bit of wall puncture that is not spontaneously closed, it can result in slow leak of blood, and you have sort of these pericardial effusions that happen within the first 7 days. But then people say, okay, I have pericardial effusions at 3 months. I think in those cases it's mostly hemorrhagic pericarditis or inflammatory process that the pericardium undergoes through when these pins are exposed to the pericardial surface. That probably sets in some amount of inflammation, and so a lot of times you end up seeing sort of serosanguinous effusions that are not very bloody. So that's at least my take on it. I don't know if the others have any opinions.
Yeah, I haven't seen any late, but it's definitely, it's the fistula of the AF ablation, right? When it's so it's definitely an elephant in the room, and definitely something we need to understand better. My personal feel is a deeper deployment. If you've been very used to Watchman, if you're going to use this as a Watchman, you are going to get some trouble. You don't really need to go this deep with this device, 1. And 2, the tension test is a tension test. It's not a tuck test. So these anchors are hooked up, and if there's some degree of force which is going to get transmitted to those anchors, and so let's not yank it out. You know, and I use tuck tests almost all the time, but the tension tests all the time. But I use to place my disc where I wanted to. So when the deflectable sheath was available, I was using to orient my disc to where it would cover the whole thing. And I think that's the fun part of the procedure. That's where you can use some of your skills to actually close the hole in leaks.
So I'm going to add just 2 points to it. I think people who are used to doing Watchman, you're used to measuring compression, whereas for the amulet device, compression is a fluoroscopic marker. So if there is any question with the compression, you don't see that offset of the waist in the distal part, or you have any concerns about the compression, then you need to do a legitimate tension test, like DJ said, the 30-second hold, turn your TUI off, TUI closed. Do a legit tension test to make sure that lobe is not moving. And when you're doing that, please make sure that you're watching on fluoroscopy, but also on imaging. You know, that's not the time. That's 30 seconds. Seems like a very long time in a lab. You don't want the imager to go start looking at the mitral valve and things like that at that time. So you have to focus on the lobe at that time. The second point about the pericardial effusions, I think there are a couple procedural steps that you have to kind of think about to avoid effusions, to keep the procedure safe. You know, obviously making sure that you always lead with the ball, you don't lead with the sheath. You make sure that you only do your clock and counterclock in the ball configuration where the anchors are not exposed, so you don't cause trauma. Once you are in the triangle, there's only forward motion. The anchors are exposed at that point, so you don't clock or counterclock. If you're recapturing the lobe, making sure that you're moving the sheath forward, but not pulling the device back, because these are things that you have to unlearn from your Watchman learning. You have to push the sheath forward. And then when you're doing a tension test or you're deploying the disc, you're not pushing the disc towards the orifice. You want to let that disc come by itself. You want the lobe to pull it in towards it. You don't want to push it in because you will disengage those anchors. So these are all like little procedural steps that you can keep in mind to avoid these unnecessary effusions.
I mean, one other little thing that I use in our lab is after we deploy the device, I usually stay in the left atrium for about 5 minutes. That's kind of an unwritten rule. In the event if you have an embolization, if you're not sure, especially a difficult one where you had multiple repositions and things like that, that 5-minute rule really enables you to capture most of the embolization, so you still have access into the left atrium. So something practical that really helps. Time it, and I'm going and doing my notes, and by the time you're done with the note, the 5 minutes is up, and make sure you reflow again, the device is stable, and then you get out. So another little thing, I don't know if it matters or not, but something that I use.
I just make a comment because we've done a couple hundred, 500-600 amulets probably, and what I've seen is we've never had an early pericardial effusion, never effusion on the table, but we've had late pericardial effusions, usually 24 hours to 2 weeks after. And kind of looking back at analyzing our 500-600 patients that we've done, we didn't have them with a steerable sheath. So that's point number one. People would think the steerable sheath would be more vicious and more, we didn't have it. So that tells me that with the steerable sheath before it got pulled, you were more fixed. You didn't have as much rotation in whatever configuration you were in. You were more stable with your device deployment. So that was number one. Number two, I think Dr. Siddiqui mentioned, I think initially on when we had our late pericardial effusions, we were more distal. And so when we deployed, we had almost like an airbag-like effect, where it almost kind of, on the distal appendage, the pins came out and created an issue. And number three, when we look at some of our ones when we had the proximal implants, we felt so compelled to say you cannot push forward in ball. And I know that's what it says, that we would always drive, we would stay in ball saying, oh my gosh, you got to stay there, and then go to triangle, and then advance forward. And what would happen is that by not injecting enough contrast, knowing that we could go forward in ball and navigate a little bit more to our target, we'd almost have the triangle, when you pushed forward too aggressively, can't. So if the triangle can't like that, I think the pins get offset a little bit, and then weeks later or a period later, there's this micro movements that create some of your late pericardial effusion. So that's some of the stuff that we've seen from our implants.
I think you're right on the point on that, yeah.
Well, thank you very much, everybody. I'm afraid there is 0 time left for this discussion period. It's coffee outside, and please, if you have a question that you've put up that's not been answered, try and find somebody to ask the question of. And you're due back at 10 past the hour.